So we are starting with aortic aneurysms, okay? And like I always say, if you know the anatomy and the whole lot, it's very good. It's important. It gives you a very fresh knowledge. But we all know that when we talk about the aorta, we are talking about that's the biggest or the largest artery within the system. And then what the artery does is that it sends oxygenated blood to various parts of the body. So when you take the aorta is the biggest what we call artery in the system, and then it will supply oxygenated blood to the various parts of the body. Now, the aneurysms or the aorta can get dilated, okay? And then because it's a vessel, it's a blood vessel, a portion or a part of it can get dilated. And when it gets dilated, it can rupture at a point. And so when it's ruptured, so when it gets dilated and then care is not initiated, and then it continues to dilate. Since it's a vessel, when a vessel starts to dilate, it gets to a point in time, the vessel has to rupture. And so when it's ruptured, it means that its function of carrying oxygenated blood to the various part of the body or to the various organs within the system, it's going to be affected. Okay. And so most of the time, even though when you take the what we call the aorta, aneurysm can happen at any part of the aorta, but most often the aneurysms mostly happens in the abdomen and that of the thorax. Okay, so the thoracic region. So that means that the aorta that is located around the thoracic region and then that of the abdominal area or the abdominal region, mostly that is where you tend to have the aneurysms happening a lot. And so when it happens, you're going to have a dilation of the abdominal aorta, or you're going to have a dilation of the what we call thoracic aorta. And at the end of the day, if it ruptures, if it continues, okay, if the dilation continues and then it ruptures, blood supply to the abdominal organs or systems that are below what we call the abdominal region, like the kidney, they are all going to be affected and then they are not going to get blood supply. Now, we also have what we call ascending and then descending aorta. So let me just touch quickly on the ascending and then descending aorta. And so just after the aortic roots, let me use this to explain this so that we get the understanding. Okay. Just let me see. Yes, I think I have it here. So let me use this. No, sorry. All right. Let me use this to explain what I want to do. Okay, I think I can equally the picture I'm looking for, I'm not getting it. But let me use this to explain. So this is an aorta, okay. This is the aortic roots here. This is the aorta. It just through down, comes down here. Now, when you take the ascending, okay. So you see ascending aorta here, then you have descending aorta here. Okay. So descending means that it is coming down. Then the ascending aorta is also up. So like we have descending, ascending. Now you could have the ascending aorta getting affected, or you could also have the descending aorta also getting affected. So what happens is that mostly when it's affected, someone was asking about pulses. We have the various pulses where you can locate them. You can have the temporal pulse, you can have the carotid pulse, and then all the various pulses we have. Then when you come down, you can have the femoral pulse also being somewhere in your groin area. Then you have the popliteal, pulses also around your knee area going down. So when you have ascending aorta getting affected, okay, when you have ascending, the one that goes up, when you have it affected, mostly pulses that are affected are pulses that are on the upper part of our body or upper extremity pulses. So for instance, you could have your carotid pulse getting affected. you could have the temporal pulses, not either there is a reduction in the strength of the pulse, or there is you might not be able to feel the pulse over there. So someone was asking about pulse, how to in terms of the pulse rating. So when it comes to pulses, it's 0 to, I think, 0 to 4 or so, or 0 to 3. I think 0 to 4. The ideal pulse is +2. So when you have +2, that means that you have normal, a normal pulse strength. This is in terms of the pulse strength. That is +2 is normal. Now, if there is an alteration in terms of the pulse, the strength of the pulse, either you have +1 or +0. +1 or 0. +1 means that there is a reduction in terms of the strength of the pulse, meaning that either there is a decrease in blood supply to that affected area. And so, for instance, let's say someone is having a descending aorta issue, or there is a rupture of the descending aorta, or they've gone to do a dissection and a resection of the ascending aorta, or descending. Let me use descending. What it means is that there could be an occlusion after the resection, and then after the resection and of the descending aorta, there could be blood supply to the lower extremities could be affected, because we've learned that the descending aorta supplies blood to the lower extremity. So you could have something like the femoral pulses becoming either +1 when it is diminished, or when there is an occlusion of that very aorta, that is the descending aorta, you could have the femoral pulses being either +1 or 0. 0 means that you can't palpate it, okay? Or even if you feel it, the pulse is not there. You can't, yeah, no pulse. That is 0. Then you have 1, reduction in the pulse strength. Then +2 is very good. That is the normal. Then you have 3 to 4. 3 to 4 means that the pulses are very strong, okay? Then you could also have the ascending aorta. So the ascending aorta sends blood to the upper part of our body. And so if you are to assess for pulses, and then you want to see any alteration with regards to the pulses and then that of the ascending aorta, if the ascending aorta is affected, you have upper extremity pulses also getting affected. So let's say you check for carotid pulse, and then the carotid pulse is, let's say, either +1 or 0, and that should tell you that maybe the ascending aorta is affected, because the ascending aorta is supposed to send blood to our upper part of the body. Same thing, the temporal pulse is also located around the head area thereabouts. Okay, I think I have a picture of it. Let me drop the pulses so that we can let me drop this on the page so that we can make reference to it in terms of the pulse, where the various pulses and where to locate them. I have questions on that too, that because you can be reading and then you come across some of these things and you'll be like, hey, what is ascending aorta and what is descending aorta? That is why I've taken my time to explain this for us. So I've sent the various pulses over there. So the upper extremity pulses, we talk about the temporal artery. So that will be temporal pulse, carotid artery. You get a carotid pulse there. Then the apical pulse too is also upper pulses. Then you talk about the brachial and the radial. The down pulses are the femoral pulse. You talk about the popliteal artery there. So that will be the popliteal pulse. Then you talk about pedal. Then you talk about posterior tibial artery. So these are the classification when it comes to the various pulses that we have, and then where you can locate them. So like I said, one thing again, upper extremity pulses in terms of their control is by the ascending aorta, and then the descending aorta is also for lower extremity pulses, starting from the femoral pulse coming down of the femoral artery in terms of it's getting affected. It's also from the femoral coming down. So that is just aorta, and then the various functions of the ascending and then the descending aorta. And so when it comes to the abdominal aorta, I'm still on my screen. I want to still use this to explain the abdominal aorta so we can get it. So when it comes to the abdominal aorta, so let's say this is the main aorta, okay. We have our main aorta here, okay. So this structure is very good for us. So if it's about thoracic, because I said that the thoracic and then that of the abdominal aorta is mostly the ones that are mostly affected. So I'm using this one to explain. So the abdominal aorta is mostly somewhere here. Then the thoracic aorta, it's also around the chest area. Okay. And so when it comes to the assessment finding, we'll talk basically on those two, the thoracic and then that of the abdominal aorta. You have the abdominal region in terms of the pain. If it is abdominal aorta that is getting dilated or the aneurysm is happening in the abdominal aorta, you get abdominal pain, severe abdominal pains. Then chest, if it is the thoracic, you also know that the pain will be also more towards the chest area. Okay, they all come with other assessment findings. We'll look at it very soon. So I just wanted to use this one to explain to us, for all of us to get an understanding of what we want to do for today. Please write it on my screen. All right. Okay, so that is just that for the anatomy part, or the part I want to use to explain my class for today. If you have a question you want to ask, if you have an input you want to make, you can also make it as well too. So I think when it comes to the pulses, Madam, the one who asks, +1 means that there is a drop in the pulse strength, and then 0 means that you are not even feeling the pulse at all. Then when it comes to 2, hey, why am I not able to? All right. All right. So was someone asking a question? I heard a voice down there.
I've gotten it.
You've got anything?
Yes, please. Thank you for the.
Okay. All right. So let's come back to what we have here. So we have the aortic aneurysms. And then so when an aorta becomes dilated, okay, that is what we term as the aneurysm. You have the arterial wall becoming dilated, and then it becomes weak and then continues to stretch. So when it continues to stretch and then interventions are not put in place, you could get it getting rupture, or it can rupture. Rupture can occur. When it ruptures, we know what happens when organs ruptures within the system. The main goal of treating what we call this aneurysms is to prevent the condition from progressing from.
When he's playing around, but the thing is, when you sit down, say no, but now
Angela, mute her for us. Angela Bennis, mute her for us. Thank you. So you have some factors that could lead to the aneurysms rupturing when they get dilated, or when the aorta get dilated, which is the aneurysms. Things that could lead to rupturing is one, when you have BP going very high. Okay, so high blood pressure is one of the things that could lead to aneurysms rupturing, because they put pressure on the area. And so when you have a question on aneurysm and you have like a BP being very high, one of the things you need to consider is by managing the BP. So you need to manage the BP so that you prevent the aneurysms from also rupturing. Another thing that patients with aneurysms or aortic aneurysms are told to do is to avoid engaging in any strenuous activity, because when they get into any strenuous activity, what happens is that it could lead to increase in abdominal pressure, and when abdominal pressure increases, the aneurysm can rupture, and then that will lead to hypovolemic shock and all those things happening. So the main goal is to help manage the symptoms and prevent rupturing. Anderson, kindly mute up for us, okay? Anderson, kindly mute up. So let's focus on the various two I did mention, the thoracic aneurysm and the abdominal aneurysm. When the aneurysm located around the chest area or the thorax is affected, you have chest pain. So you have the pain more extending to the neck area, the shoulder, and that of the abdomen, like that. Kindly mute up when you join us. My co-host there, those who are helping me to be co-host today, kindly help me do the muting. Kindly help me do the muting. Let me make a couple of you co-hosts so that in case I go off, it doesn't affect our class. So we are talking about thoracic aneurysm, okay? And then the assessment findings we can associate with it. So in there, you have the pain being more towards the neck because we are talking about things around the chest area. So if you have thoracic aneurysm, it means that more towards the upper part of the body, that is where the pain will be mostly felt. And then it can extend to the abdomen as well. Then you could also have syncope because you have what we call blood supply getting affected. Okay, so there could be some form of hypotension, if especially when it's rupturing. You could have dizziness accompanied. You could have dyspnea as well too, difficulty in breathing. Just assume someone is having the chest area, the aneurysm or the aorta around, they're getting dilated and then putting a lot of pressure on the structures over there. So the patient will have difficulty in breathing. Increase pause, okay, as a compensatory mechanism just to help circulate blood through the system. Then there could also be cyanosis and then hoarseness, difficulty in swallowing because of the pressure from the aneurysm, okay. Then when it comes to the abdominal aneurysm, you have the prominent pulsating abdominal mass at or above the umbilicus. So when you look at the picture I used to explain the aneurysm or the aorta for you, you'll see that the abdominal area, or when you look at our abdomen and you have the abdominal area, the aorta over there getting dilated, it puts pressure over there, and then the place also becomes a bit more, distended. So you could have abdominal distension as well. So on palpating, even though when it is noted that someone is having aneurysm, you have to be very careful when you have to palpate because you don't have to apply a lot of pressure in palpating. But when you do that, you can cause rupturing or you can put pressure on the area and the rupture can occur. So the patient will complain of a pulsating abdominal mass at or above the umbilicus. Then you could also have abdominal distension. You could have tenderness on deep palpation. When you palpate, you could have deep palpations. In deep palpation, there's tenderness. Then abdominal or lower back pain. You could also have systolic route over the aorta. That's when you do your auscultation. You could hear some form of abnormal sound during I could have some form of abdominal abnormal sound on auscultation around the area where it's affected. So these are the various associated assessment findings you can associate with both abdominal and that of thoracic aneurysms. Now, the most serious form of it is when it's ruptures, okay? And so mostly they won't just give you just aneurysm, or if they are giving you aneurysm, they will just give some of the things you do to prevent it from rupturing. Sometimes you could get a ruptured aneurysm. So when aneurysm ruptured, especially they like acting a lot on the abdominal aneurysm. So you could have a ruptured abdominal aneurysm, or a ruptured aneurysm will present with severe abdominal pain and that of back pain. So the pain will be more severe. Then you have lumbar pain that radiates the flank and the groin area as well too. Then you have hypotension. Remember when the aneurysm is ruptured, patient is going to bleed internally. So when you bleed at the end of the day, you're going to have hypovolemic shock, or shock is likely going to set in. So in shock, we know that hypotension is there. you have tachycardia, you have tachypnea, and then you have hematoma at the flank area. And so the bleeding, you could see the flank area would have some form of discoloration around the flank area, telling you that the patient is bleeding. So you could have hematoma at that place. Now, when it comes to the aneurysms, before probably a patient is sent in for a dissection and then resection of the aneurysm, patients, at least we need to manage the pain. We need to educate or manage so that the aneurysm doesn't get ruptured. And so in that instant, we know vital sign is very, very important. Everybody knows this. Then we have to assess for the pain. Then we question patient about any pulsation in the abdomen, because we know that when there is an abdominal aneurysm or abdominal aortic aneurysm, there's going to be some form of pulsating mass in the abdomen. So when you have that, I think the most serious form of it is the abdominal aneurysms. And so you need to ask the patient to tell you about, as to whether there is any form of sensation with regards to any pulsation in the abdomen, so that you can know that the thing is actually enlarging, and then any mistake could put the patient at risk of having the aneurysm rupturing. Then you avoid palpating the abdomen if abdominal aneurysm is suspected. So like I was saying, when you palpate the abdomen, you put pressure on the abdominal contents or the abdomen, and then that could lead to the aneurysm rupturing. So one thing is that we don't palpate, or we should avoid palpating the abdomen if it is suspected that someone is having abdominal aneurysm. Then you check for peripheral circulation. We've learned about the pulses, and we know that when there is any alteration in blood supply to the various extremities, especially the lower extremity and that of the upper extremity, the pulses are likely going to be affected. And so if the pulses are going to be affected, like I explained, you have a reduction in terms of the pulse strength. And we also know that if blood supply to an area is decreased, mostly the temperature of the place is also there's an alteration in the temperature. You could have a cold area when you do your assessment. If blood supply is cut off or is reduced, there's some form of coldness, and then you could also have some form of cyanosis around the area too. So you have to assess the extremities to see as to whether blood supply is adequate. Then you have to observe for signs of rupture. And so if it ruptures, there's going to be back pain, there's going to be abdominal pain, changes in the vital sign, and shock is also there. So these are things that will tell you that a patient with either a thoracic or any form of aortic aneurysm, the aneurysm has ruptured. If these things are found in our assessment or in the question, it could tell us that the thing has ruptured. And so you need to promptly inform the healthcare provider, and then the necessary interventions you need to put in place. Then you instruct clients with an aortic aneurysm to report immediately the occurrence of chest pain or back pain, shortness of breath, difficulty swallowing, or hoarseness. Okay. This all could tell you that the thing is rupturing, thing is getting enlarged, and all those things. So these are the things that you do for clients before they go in for what we call a resection of the aorta. Okay. So before the client is taken in for a resection, those are the things that I went through, and the things that at least we do for the client. Then, in case it ruptures, the patient has to be taken in, or even with the dilation itself, the patient goes in for a resection of the aorta. That means that either they are going to harvest an aorta from a different part of the body and then use it to replace the old one. So they will do a graft, and then they will sew the end together so that the blood supply can continue. Or they can even use what we call a prosthesis, okay, to do that as well too. And so the abdominal aortic resection is a surgical resection or excision of the aneurysm where the area is excised, replaced with a graft that is sealed end to end. Okay, so they join a graft with so they cut where the problem. I believe you know what I'm trying to picture. What I'm trying to say. They will cut the area, then they will find a graft and they join the two together, and then circulation of blood flow continues. Now, when it comes to this, one of the main things I want us to take note of is the post-care management. After the client returns back from the resection, what are some of the things? Pulses management or pulse assessment is very, very important because after the resection, if there is any form of pulse alteration, that could indicate that the aneurysm, the area that was worked on, either there is an occlusion or the integrity of the area is affected. That is why you have the pulses getting affected. And then you have to, in terms of patient positioning, how do you position patient after aneurysm resection? When it comes to the pre-op, before patient goes in, pulses are very, very important because you need to assess the pulses. When you assess the pulses, you keep it down. If patient goes in and they return back, we know that we have to continue to assess the pulse. So you have to now compare the new pulses after the resection to the old pulses that the patient had before they went in for the resection, so that you compare the two. If there is any form of alteration, you could inform the healthcare provider on that. Then you also instruct the clients on some form of coughing and deep breathing exercise as well too. You teach them because when they return back from surgery, they will need to kind of engage in some form of coughing and deep breathing exercise as well. So you have to monitor the vitals after the procedure. Then pulses are very, very important, as I said. So you monitor the peripheral pulses distal to the graft site. Then you also have to monitor for signs of occlusion. And if there is occlusion, there's changes in pulses, cold to cold extremities. Like I was saying, if the extremities are not getting enough blood supply in terms of the temperature around the area, I mean, there is some form of coldness around the area. That tells you that there is some form of occlusion. And then you look at for any blue or color discoloration around the flank, the extremities, or you have to then severe pains or abdominal distension. If you have these things, it could indicate that there is an occlusion of the graft or the area that was worked. There is an occlusion, so you need to inform the healthcare provider. And then you have to also limit elevation of the head to about 45 degrees. Okay. The thing is that you don't want to put a lot of pressure on the area. And so you don't raise the head of the bed to high Fowler's position. You only raise to 45 degrees. That is what you can only do. Okay. So you don't raise the head of the bed to 40, more than 45. Okay. You can only raise up to 45 degrees just to prevent fleshing of the grafts. Then you have to maintain an NG tube in case there is an NG tube in place to empty the abdominal contents. You need to make sure that the NG tube is in place, and then you can only remove it when bowel sounds returns, and you monitor for the bowel sounds as well too. You monitor the kidney functions because the aorta, which supplies blood to the lower extremities, you saw where the abdominal aorta is. So if the abdominal aorta is affected, it means that the kidneys are not going to get enough blood supply. So you need to monitor the kidney functions. Then that means that urine output is very, very important. And in urine output, we are looking at 30 to 50 ml per hour, which is the standard we all know. And so if you have anything less than 30 ml per hour, sometimes you can see like 25, but I think the standard that you see it in most books or most of the Q banks is 30 to 50. So you need to monitor the urine output. Because we are talking about kidney, you have to monitor the kidney, your creatinine level, BUN levels as well too. And I believe we all know the BUN level. I think BUN is what, 10 to 20. And so above 20, it means that above 20 means what? fluid volume overload or fluid volume deficit?
Deficit.
Above 20 is fluid volume
Deficit.
deficit. Okay.
It means dehydration.
Okay, very good. Then you have to look at your creatinine level as well too. Then you have to monitor the respiratory status. Auscultation of the breath sounds are also all important because it could have some form of respiratory complications as well too. Deep coughing and coughing, deep breathing exercise, as well as splinting the incision area is also very important just to prevent lung collapsing as well too. Then you monitor the sites for signs of infection. If there is infection, we know that there's going to be some form of abnormal drainage from the incision side, some form of redness or temperature increase in warmness around the area. You could also see it in infection around its incision side. Then pain medication will also be very important. Your antibiotics will also be there. Then you encourage clients to ambulate as prescribed. Then what I want to stress on is activity. So you prepare the clients for, discharge home regarding management, and then when the patient goes home, they will need to avoid any form of heavy lifting. And so if they need to lift, they don't need to do above anything. They shouldn't lift any weight more than 15 to 20 pounds, okay, for 6 to 12 weeks post-procedure. And so what you do is that you have to educate the patient that they shouldn't lift anything that is. Madam Esther, I can see you are very tired.
Sorry, oh.
I can see Madam Esther is very tired. Sorry. All right. So heavy lifting is avoided. Patients should avoid heavy lifting. Then any activity that requires pushing, pulling, or straining, they would also have to avoid it. So that means that we also have to avoid constipation. Okay. But when someone is constipated, they strain during, when they are freeing themselves, they strain. So they would need to avoid constipation and all those things. Then in terms of driving, they can only drive when it is approved by the healthcare provider. So you instruct clients not to drive a vehicle until approved by the healthcare provider. So that is on the abdominal aneurysm. I think we'll do quickly on the thoracic aneurysm. The care is quite the same if they go in for the repair or the resection of the aneurysm. The care is the same. I think the pre-op is the same. Then the post-op, they are all the same. What do I have here? So I think I have the same thing. It's what I have here. You monitor the vitals, very important. The neurostatus is very important. You monitor for signs of hemorrhage, BPs, and all those things. I think I've discussed that or I've talked about that. And then they could also have some form of chest tube in place, okay, to remove excess fluid, okay, or any blood that might stay in there. They could, put in a chest tube. And so when there is a chest tube, you need to monitor the amount of blood that is being drained every hour. And so if you have a patient with a chest tube draining more than 100 to 150 mils of blood or fluid per hour, that should tell you that patient is the fluid that is being drained is more. So you need to inform the healthcare provider. It could be that patient is bleeding more internally. That is why such an amount of fluid is coming out. So you need to inform the healthcare provider on that. You assess for sensation and then extremity pulses. I think I've talked about that. The respiratory studies, not engaging in any form of activity that put pressure on the area, not lifting anything above 15 pounds, and then not pushing, pulling, straining. Driving is also here. So these are some of the things that at least they run through all of them when it comes to the aneurysms. I'll drop the aneurysms here so that we can quickly go into the other part. Then we do that one, and then we move up from there as well too. So if you have any question, any input you want to make on the aneurysms, you can bring it on board as well too before we move on. Okay. Yes, Madam Janet, your hand is up.
Yes, I want to find out, is it always operable or it can be managed with drugs or other things?
So I think the main management is there. What is it? Doing the surgical management. That is the main management, because you wouldn't want it to continue to dilate. Okay. So when it is noted that someone is having an aneurysm, definitely, I'm sure the person will be sent in for a resection to be done.
Okay. Okay.
Yes.
Thank you.
Okay. Is there any other question? Any other one with okay. Let's quickly, I won't talk anything much on hypertension because I believe we all know hypertension as nurses here. So we only talk much a bit about what the NCLEX would, and some of the things at least I want us to take notes of. Then we'll look at one or two management, some patient education. Then we quickly go into question. I think in hypertension, my questions will bring a lot on hypertension so that we use that to learn a bit on hypertension as well. But what I want us to take very good note of is the risk factors. I think I'll stress much on this. The risk factors, the modifiable and non-modifiable. Okay. I think I've grouped all of them together. I didn't separate them, but we have the aging, which is non-modifiable, family non-modifiable. What again? Then you could have obesity, which is modifiable because we can do something to control with smoking, stress and all those things. Alcoholism, we all know that all these things, either they lead to what we call atherosclerosis. Oh my God. Either they lead to more cholesterol being built up, or they lead to atherosclerosis being forming within the vessel, the vessels, and then leading to more fluid staying, affecting. Yes, Madam President, your hand is up.
Yes, please, I wanted to talk concerning the question she asked about if all the aneurysms are operable. So
okay.
I read somewhere that when it's above 6 centimeters, that's the aneurysm.
Okay.
That's when they do a surgery. But when it's below, they send the patient home and advise the patient to do follow-up visits, and then they manage the patient's BP. So what happens is that the patient returns to the patient notifies the primary healthcare provider if they have like a persistent BP elevation.
Yes.
They have like soreness or like fullness in their umbilicus, like all those complications that there might be like a rupture or like an increment of the circumference of the that's when they return. So I just wanted to touch on that.
Okay. Oh, okay. Okay. Thank you. Madam Amma, you have been unmuting yourself. I don't know whether Seki, Madam Amma Seki. We've been getting a very feedback from you. Do you want to let me mute you for now. Kindly mute up some of the what we call the feedbacks. Okay, I believe we all heard it. It was a very bad feedback. Okay, so when it comes to hypertension, that I think when it comes to the medication, some medication that could lead to fluid being retained, like steroids. Okay, so when you look at when you do endocrine and you look at the steroids, we know that someone with Cushing's, okay, Cushing's, they have a lot of steroids within them, and the steroids also affect the fluid status. Okay, they tend to cause more fluid to accumulate, and when more fluid stays within the system, we know what happens. It elevates one's blood pressure. And when it comes to the blood pressure, I'm not going to give values. We know the values. So anything above the 140s, I believe we all know that. But we'll be looking a bit much into some questions that were touched on all those areas. Then we looked at the key assessments you can look out for. Some may be asymptomatic. You have headache, which is very important here, especially when the BPs are very high. It leads to some form of increased ICP. And we know when ICP also goes up, you have headache, you have some form of visual disturbances as well, too, especially blood supply to the vessels that supply, blood to the eye will also be affected. So there's some form of visual disturbances. You have dizziness, chest pain. Tinnitus can also happen, the flash face and epistaxis, especially when the BP is very, very high. Patients could have bleeding in the nose as well. Now, in hypertension, the important thing we all need to know is controlling the BP. How many times I have to tell people to mute my brain? Yes, okay, muted them. Let's see if someone will mute herself again. You have, the goal is to, manage the pressure, reduce the pressure, prevent organ damage, okay, the kidneys and all the various, organs within the system, just to prevent damages. Then you have, you obtain blood pressures in the various arms, and then when the client is in the supine and standing position, just to compare in terms of blood pressure monitoring. You compare the BP, prior to documentation, and then even giving your medications. You determine the family history, then you will have to weigh the clients daily. Your medication, we'll go into the medications proper. So we'll talk a bit more on the various blood pressure medications or the cardio medication. We'll talk a bit more into them very soon. Then dietary management, very, very important. Sodium, we know that when someone is having hypertension, the person is educated in terms of salt or sodium intake. Today, my people are stressing me. You have to educate patients on salt intake so that they need to.
Okay. I beg you.
You need to educate them on salt intake or sodium. Okay, they will need to limit the intake of sodium. You have to assess for other organ damages such as visual changes and then retinal damage. Sorry, you have to look at any form of retinal damage, any form of visual changes with hypertension. You need to report that as much as possible. Then you have to assess for any form of cardio changes there. Extended neck veins, heart failure could also happen. So you have to, any form of increased heart rate, any form of dysrhythmia, you have to assess for all those things. Chest X-ray could be done. There could be some form of heart enlargement or cardiomyopathy. So you need to do chest X-ray to assess for the heart. And then new assessment is also very important. So right now, we know that the kidneys play very much important role in regulating what we call blood pressure. And so if you have blood pressure, kidneys are one of the things that need to be assessed, and then you do all other laboratory investigations to assess. When it comes to the non-pharmacological, you look out for weight reduction, which is very, very important. Then the sodium restriction, so they can only consume about 2 grams of sodium per day. So that is one thing that when it comes to the sodium in terms of salt reduction, It's very difficult, especially people who take sea salt, just to tell them not to take salt at all or sodium at all. So they have to rather reduce the amounts they are taking. Okay. So dietary sodium restriction to about 2 grams daily as prescribed. Then they would have to also read on all other food labelings, especially when they go out to buy any prepared food. They will need to read on the labelings to see the sodium content in there. Then they will need to also avoid alcohol or moderate alcohol intake. You see what they are saying here? Moderate intake of alcohol and caffeine containing products. Okay. Then you initiate exercising, avoiding smoking. Then you have to also eliminate unnecessary medication that may contribute to hypertension, especially something like the NSAIDs, over-the-counter medications like NSAIDs. Okay. You know, NSAIDs also have effect on fluid status in the system. And so people who have hypertension, mostly taking NSAIDs are not really advisable. So they will need to also prevent the intake of any form of over-the-counter medications that are not prescribed. Now, when it comes to the serious, when the pressure starts going up, you tend to have the crisis form of it. That is when you have the systolic blood pressure being over 180 with diastolic 2 over 120. This is where you have hypertensive crisis. And at this point, the BPs are very, very, very high and becomes very life-threatening. The consequences of it are it could lead to CV, it could lead to kidney failure, it could lead to some form of other cardiac diseases could all result in there. And so you have to manage the patients and make sure that you are reducing the pressure. But when it comes to blood pressure management, one thing too is that essentially you don't need to, we call what we call permissible hypertension. In permissible hypertension, you don't drop the BP at a faster rate, especially when you are giving the IV nitroprusside. Okay, nitroprusside is, I think, it's a vasodilator that is used in managing hypertension, especially the crisis. When you are giving it, they have a very the effects on the pressure. Okay, when you give it, it manifests within a very short period of time. So when you are giving it, you have to make sure that you are monitoring the pressure, making sure that you don't drop the pressure drastically. Because when you drop the pressure drastically, patient is likely going to go into what we call CVA or stroke. So you need to be very careful on that. You have to emergency treatment required to prevent damage to organs like brain, heart, and the kidneys, the eye as well too. So on assessment, you have the pressure in there being the 180 over 120 in terms of the pressure for hypertensive crisis. You have headache, you have drowsiness, you have blurred vision, and then other neurological changes, confusion could be called tachycardia, tachypnea. They have dyspnea, then you could have cyanosis, and then seizure could also occur. So when you are managing someone with hypertensive crisis, you need to institute seizure precautions. In case there is seizure, you have to manage the seizure as well. Now, in hypertensive crisis, airway is very, very important because the PPs could go up. You have dyspnea here. So if there is dyspnea, you have to make sure that you are protecting the airway. And then with our prioritization, you know that ABC is very, very important. So airway, maintaining a patent airway is very important. So antihypertensives, IV. So when you are giving the IVs, you need to make sure that you are assessing the blood pressure every 5 minutes. Okay, you monitor the BP every 5 minutes when you are giving your IV antihypertensive in a patient with hypertensive crisis. Then you monitor, maintain bed rest. You elevate the head of the bed to at least 45 degrees because of increased ICP that could happen. You have to elevate the head of the bed to reduce any form of, ICP changes or ICP improvement. Then you have to also assess for hypotension from the medication you are giving. And then you place the client in a supine position if there is hypotension, because we know that when there is hypotension and the client is allowed to walk around or is allowed to sit, the patient can fall. So fall can happen. That is why you have to let the client be in a supine position. If there is hypotension, you have to have your emergency resuscitation equipment on the bedside, your oxygen available, and all other needed things. Then you monitor the medication you are giving. you insert catheter to monitor kidney function. That is a urine output, very, very important. And then you inform healthcare provider if it is noted that someone with hypertension, given your medication, is having oliguria or anuria. You need to inform the healthcare provider. That is why we learned about the normal urine output the client has to have. Then the last thing we talk about on this before we go through some few questions is client education with hypertension. We know that when it comes to hypertension, clients adhering to treatment plan is one of the very big problem when it comes to client. They tend not to adhere to the treatment regime. So you need to educate clients on the importance of adhering to treatment plan. Then you describe the disease. I mean, everything we know when it comes to NCLEX and patient's education. We know all those things. We have to assist the client on planning on exercise, okay? Gradual exercise, avoiding heavy lifting, and then any form of exercise that would demand more, energy. Clients have to do exercise gradually. Then you encourage them to express their.
Yes.
I'm Janet. And I'm Janet. Janet, kindly mute her for us. I'm sure she just joined us. Oh, God. Okay. So you need to educate clients on, some emotional changes that could come, and then the importance of stress. Because we know that stress too is one of the things that could lead to what we call one of the predisposing factors or risk factors. Clients have to reduce stress. As well, relaxation techniques all need to be talked about. Then how to monitor blood pressure in the house, you need to also touch on that. And then daily blood pressure monitoring. Then importance of lifelong medication. We all know that you can't cure hypertension. There's a client who need to be on the medication for a very long time. Then dietary modification, sodium intake, calories, fats, and then cholesterol. Clients has to reduce them as well. Then you provide a list of products that contains sodium, especially if they like buying products outside, like canned foods. Most of the canned foods contains a lot of sodium. So clients needs to read on the canned foods to know the sodium contents before they go ahead to take. Then you instruct them on how to shop for and then prepare low sodium diet. So this is what I'll touch on when it comes to hypertension. We'll end it here for now. Go through some few questions on hypertension, and then the aneurysms we take. Then from there we move into the medication, and then we'll run through the medications as well. And then we'll try to see what we can do next for today. So that is the first part of my class. If you have a question, you have an input you want to make, you can make it as well too. Yes, Madam Anna.
Yes, I just want to apologize for the feedback from my end. I can't see from my phone, so I was trying to.
Okay, change device.
Yes, I was trying to set it up on my device. That's why we have on the laptop.
Oh,
so
okay.
that I can see the text.
Oh,
so
okay.
that was waiting for the feedback.
Oh, no problem.
Yeah.
You are forgiving. All right. Yes. Okay. Then
Hello,
let's.
sorry.
Yes,
Can I ask a
Madam.
question?
Oh yeah, you can
I
ask
think
me.
I got lost at a point.
Got
But
lost
in
at the
order
point.
no, I'm okay. I'm just saying the beginning.
Okay.
It's just a
Okay.
little something.
Okay.
So you are saying that when it comes to aneurysm,
Okay.
the pedal force it has to do with aneurysm caused at the lower extremity, right?
He said I said that the pedal
I'm
pulse.
just asking. Yeah. Is it aneurysm caused is it the lower extremity that you assess the pedal or pedal pulse, like when the aneurysm is
No. So in actual sense, if someone is having aneurysm, okay, like abdominal aneurysm or whatever aneurysm the person is having, you need to assess all pulses. Okay, whether upper extremity pulses or lower extremity pulses, you need to assess for all pulses. But what I stressed on was if they become specific that a patient with a descending aortic aneurysm, okay, a descending aortic aneurysm affects the descending aorta. And I said that the descending aorta supplies blood to mostly to the lower part. When you look at the structure of the aorta, like it comes down, descend. So mostly when a descending aorta, in your question, if you have a descending aorta specifically being talked about, and they are asking you which form of pulses are you going to assess in a descending aorta getting affected, you assess lower extremity pulses. And so I think pedal pulse forms part of the lower extremity pulses. You have femoral pulse also being part of it. And then I also said that if the question is asking you about, let's say, an ascending aorta getting affected or ascending aortic aneurysm, and they are asking you about which form of pulses are going to be affected in a patient with ascending aortic aneurysm, then you look out for the upper pulses or the upper extremity pulses, where I did mention of the temporal artery. Then you have the temporal pulse affected. You have the carotid artery there. You could also have the radial pulse being upper. You could also have the brachial artery also there. So brachial pulses are also going to be affected. I think that is what I stress. But if it is generally on aneurysm, if a question is asked on aneurysm without them being specific, and they are asking you about what pulses you are going to affect, I mean, go for all pulses, or yeah, go for all pulses. That is what I want to say. Madam Zara. Is Madam Zara with us? I want to know if she's comfortable with what I said. Okay. So we have a question. A nurse is caring for a client who is awaiting surgery for aortic dissection. What should the nurse do until the client is admitted to the operating room? Sorry, we have SATA. The nurse should position the client in a high fowlers. The nurse should ensure the client has a quiet environment. The nurse should maintain a systolic pressure between 110 to 120. Then we have the nurse should provide morphine as needed to manage pain and anxiety. The nurse should regularly assess the client's brachial and radial pulses. Yes, I'm waiting for our answers, or we have answers in the section, comment section already. Okay. Yes, let's come up with our answers. Okay. I'm waiting. I want someone to talk. Okay. No one is ready. We all want to answer in the comment section. All right. Okay. Yes, Priscilla.
Yes. Please, I'll go for 2, 3, 4, 5. The reason is
Okay.
I'll take one out because you mentioned earlier that we should maintain the patient in 45 degrees, the head of the bed, because you want to limit pressure on the aneurysm to prevent rupture. And then in controlling the blood pressure, I mean, anything to prevent strain to cause rupture of the aneurysm, you'd like to maintain a quiet environment for the patient. I mean, to prevent any anxiety, because all those things can raise your pressure and then it will end up rupturing the aneurysm. And then also, I would maintain the systolic pressure between 110 and 120 because I know that that's within the normal range, so that's okay. And I also give morphine because I'm managing pain and anxiety. And anxiety and pain can raise your blood pressure, which can cause the rupture. So why not? And then I'll assess the brachial and then the radial pulses as well. You just said right now that when a patient has aneurysm, it's better to check all the pulses. Yes.
Okay. So you are going for, except one you are taking out. Okay. Was there another? I saw another and the person has dropped it. All right. Let's see. Let's see what we have in there. So we have 2, 4, 5. I said someone is having an aneurysm, access for all pulses. That option there just gave us some pulses you should access for. So the fifth one is not part. It's a wrong answer.
It was the fact that it said like, so we are supposed to check all peripheral.
All pulses. Unless, like I said, they tell you that like
it's descending or ascending.
Descending or ascending. That is where you tend to look at which pulses
Alright.
are affected. Okay.
Okay, thank you.
Okay. We have a client report to the emergency department complaining of chest tightness progressing to their back. Their pulses are equal throughout. A BP of 170, 120, a heart rate of 65, a temperature of 37.2, that is 99 Fahrenheit. Which of the following symptoms would alert the nurse to call the healthcare provider immediately? We have the client develop worsening chest pain and then weakness in their legs. Sorry. The client's blood pressure increased to 180, 120. Then we have the client states that they stopped taking their antihypertensive 3 months ago. The client is cold and diaphoretic. Which of these will prompt you to inform the healthcare provider immediately?
Hello.
Yes,
I think
Madam
I'll
Zara.
go for 2
Okay.
because 2 is an extreme high blood pressure. Which can cause like, because you said earlier that one of the causes of aneurysm is high blood pressure. So there can be a rupture of aneurysm somewhere. Like that's what I think. So yeah.
Okay. Okay. All right. Our colleague is going for 2 and she thinks the blood pressure in there could put more stress on the aneurysm and could lead to rupture. So she's going for 2. What do you think? What are you going for? What do you also have in mind? Yes, Madam Priscilla.
Yes, I think I'll also go for 2 because I think 120, 180, 120, that's a hypertensive crisis. So it can lead to other complications. So 2.
Okay. That's okay. Yes. I want someone's another last contribution, then I move on. Someone with any other answer apart from what our colleagues are saying. Is there anyone who is thinking of a different answer? Come up with your answer. Probably you are right. Okay. Or probably your own will also add up something, learn something from your own. Then we pick it up from there.
Okay, for me, I'll choose number 4
Okay.
because I think the patient is kind of going into shock.
Okay.
Because I remember when you were teaching about the aneurysm, you made mention of signs of shock. So for me, I'll choose number 4. Thank you.
Okay. But a question to the whole house. Which of these assessment findings could indicate that aneurysm is rupturing?
One.
Worsening of pain. 1.
You know why the 2 is wrong? If you look at the blood pressure, okay, the client came with 170, 120. It's only the systolic that has gone up just by 10. Just a slight change. So that will really not be something that you need to rush and inform her, but there is just a 10 increase in the systolic. The diastolic is even the same. But when you look at the assessment in there, it is the chest pain, worsening chest pain, that could tell you that aneurysm is kind of probably rupturing. Okay. So the answer is the 1. I think someone went for the 1. I wanted the person to talk. I saw 1 in the chat box, but the person did not own up to tell us why she was going for the 1. I was quite interested in that.
Hello. Hello.
Yes.
Yes, I chose 1.
You chose 1. But
Yes,
you couldn't come up with your
No, but the point the point was that I was just I think
okay. You're just doing
no, I think I was the first person who answered and I chose 1. And my concern was the increase in pain.
increase
So,
in pain. Okay.
yes, my concern, I think I can't quite get the question very well.
Okay.
It wasn't the answer very well, but I think
Okay.
I saw the increase in pain, and then the blood pressure was already high. So my
Yes.
concern was because the blood pressure was already high and there was an increase in pain, which means
There's
there was
a change.
aggravation. Yeah, there's a change in
Yes.
the
Yeah,
patient's condition.
client's condition. Yeah, if you look at the blood pressure, there's no much change in the blood pressure if you look at what the client presented and then the initial pressure. Okay, if you compare the two, you notice that there hasn't been any much change in them. All right. So we have a surgical nurse completing an assessment for a client who had surgery of the ascending aorta. So the following process is of the highest priority for assessment for this type of surgery. It's a SATA. You have temporal, you have carotid pulses, you have the salis pedis pulses, you have the radial pulses, you have femoral pulses.
This one there. Temporal carotid radial.
This one there. We've stressed a bit much on it, so we can all come up with what you can even refer to the picture I sent on the page, then you can make reference to that. Okay. So when you come across these things in your readings, you can now make it up that okay, these are the process. So what I see people going for 1, 2, 4. Is it 1, 2, 4? 1 is temporal, 2 is carotid,
4,
4 is
then
radial.
4 radial.
Okay. All right. So that is fine. You have those courses getting much more affected. Do I have this here? This question. A client is admitted to the intensive care unit with non-specific ST with changes in a chest X-ray that was non-diagnostic. The client has noted hypertension and chest pain. So the following diagnostic test would the nurse expect the healthcare provider to order? A CT scan of the abdomen, a repeated 12-lead ECG, a transesophageal echocardiogram, then a repeated chest X-ray. All right. I'm waiting. So what this question, okay, I don't want to talk about. Just give me your answer and why you think you are going for a certain answer. Don't come up with your answers, okay? Probably, okay.
Please, is it SATA or we are choosing one?
Just one. Okay. Some people are going for 111. They're going for an X-ray.
4. I'm going for I'm going for 4. I'm going for 4 because they said they're non-diagnostic. So I think a repeated X-ray will be fine.
Okay. Hey, who is writing on my screen? What is it, my co-host who is writing on my screen? Okay. So we are looking at this question is actually telling one to assess what you can use to actually diagnose an aneurysm. Okay. The kind of investigation you need to do, diagnostic investigation you need to do for an aneurysm. Okay. So we'll learn together. But so I think it's something I didn't touch on my initial presentation. So I decided to bring it here so that we learn from it together. In case you see it somewhere, but I see others going for 1, others going for 2. Some people think a 12-lead EKG needs to be done, a CT scan will need to be done. What do you also think would need to be done? Okay, let's learn together. Okay, so the third one is what is the most the diagnostic investigation that is done, okay, in terms of as to whether you use X-ray or CT scan, you use transesophageal, okay. Yes, transesophageal echocardiogram. So it kind of help you to visualize to see as to whether there is any form of tear or aneurysms in there. So that is what is used. So we've learned something here. It wasn't part of what I presented initially. So in case you go and meet it somewhere, you need to know that we are not going to use a chest X-ray. We're not going to use a CT scan. We use transesophageal echocardiogram to diagnose what we call someone with an aneurysm. Okay. All right. So let's see this. A client is admitted to a vascular surgical unit after an aortic aneurysm repair. So the following actions will help to ensure patency of the surgical grafts, SATA, to measure an early CVP, that is central venous pressure, to ensure the client has a mean arterial pressure over 60 TV, to monitor the client for an elevated white blood cell count, 4, monitor the client's early urine output, 5, monitor diuretic therapy as ordered to prevent hypertension. Yes. 1 4 1 4 5 3 4 5. Who is talking today? All the people who talks in my class, they've all decided to be mute today. That Presla, who else? A lot of you, Madame Lako. Lako, are you with us today? Oh, Madame Lako is not with us. They have not heard from you, Madame Lako.
Yes,
Close
boss.
again.
Yeah.
You are here, okay.
Yes.
All right. I haven't heard of you. That's why I want to worry you small.
I'm here.
Okay.
Yeah. I'll equally go for 1 4 5.
1 4 5. Okay. Okay. Yes, Madam Presla.
Yes, please, I'll go for 1 4 5 because it says helping to ensure patency of the surgical graft. I'll first choose 5 because Mr. therapy, diuretic therapy has ordered to prevent hypertension. You are controlling its graft. You have to control hypertension, otherwise the graft will leak. So, and then also monitor the client's early urinary output. And we made mention earlier of monitoring the urinary output to see that there's perfusion going on, and also to ensure early central venous pressure. I mean, I think all these ones will ensure patency of the surgical graft. So that's why. I mean, I will take out 3 because monitoring the white blood cell count is not going to do anything to the patency. And also, if you are to increase arterial mean pressure over 65, that's like increasing. That will increase the blood pressure. I don't know, but I'll just go for 1 4.
But do you know a little bit about the arterial pressure, the mean arterial pressure? Do you know anything about it, Presla, Madam Presla?
All right, I know it helps with like perfusion of the organs when the arterial pressure is.
And what is the normal range?
I think it should be like, is it 60 to 70? I'm not sure. If I'm correct, I'm not sure.
Okay, thank you. So you are taking 1 4 5.
Yeah, yes, please. 1 4 5.
Okay. All right. Hey, I saw 90. Is it 99? 93 to 99. So Nanaya. Nanaya is giving us a different answer. So apart from the white blood cell count, okay, all these things in there helps to ensure a patency of the graft. So in essence, what this question is trying to ask us is to limit anything like more fluid staying within the system. And so if you look at all these things, the 1 2 4 5, they all have to do with maintaining like fluid volume. Okay. The reason why I was asking you about the mean arterial pressure is that the mean arterial pressure tells you like how well blood is being circulated. Okay. And the normal is between 65 to I think 105, 105. Yeah, that is the normal range. And so if you have a CVP, if you have mean arterial pressure less than 65, it means that the blood circulation is affected or blood circulation is being affected. And then organs are not getting enough blood supply. Organs are not getting enough blood supply. If you have CVP, I said mean arterial pressure being less than 65, it means that organs are not getting enough supply. And if you have it also being more than 105, it also means that there's more fluid within the system. So that's why it says that ensure the client has a mean arterial pressure over 65. So if it's over 65, it means that it's within the good range. Okay. But we know that WBC count has no effect on fluid status. That will put more pressure on the graphs. Okay. But you know, I believe you all know the calculation for mean arterial pressure. If you don't know it, you can Google for it. Google for it. It's not that difficult. They can give you. I think there are some questions on that. They give you the blood pressures, and they ask you which of them, together with their mean arterial pressure, and they ask you which of them you have to make a follow up on it. So you need to know. You use the systolic and then the diastolic in calculating for the mean arterial pressure. That is it. Okay. A client asked the nurse why hypertension is a risk factor for stroke. How should the nurse respond? We'll do one or two, then we'll end it there and then move ahead to do the next part of what we have for today. So we have hypertension can cause the right ventricles of the heart to enlarge. Hypertension is a primary cause for renal failure. We have hypertension may mimic strokes due to retinal hemorrhage. Then hypertension can cause emboli to migrate to the brain. This one here, everyone here should be able to produce a correct answer to this, and that wouldn't be a concern. So that is quite for, we all know that when there is high blood pressure, clots or thrombus can form, travels to the brain, causes there's one question I want to see if there's one question on hypertension I wanted us to do. I wish I get to that very soon. But this is on delegation. The nurse is caring for a client with hypertension. So the following procedures can be performed by an unlicensed assistive personnel, that is a UAP, that is assigned to a client with severe hypertension. We have assessed clients for palpitations, change soil linen caused by diuretics. You encourage the client to consume a diet low in sodium. Then you will have to administer your calcium channel blockers. Which of these can be performed by a UAP?
Sorry.
Yes.
Mama, sorry. Mama, Mama Chiraga. Mana Chiraga. I said that I'm with you. Achia.
The serious obvious.
All right. We have, okay, 2. Okay. Means that we all agree that the UAP can change the learning. Someone with, I wouldn't want us to go through this. This one was on ascending aorta pulses. I think we've done this very shortly, not a while ago. Is it what I'm looking for? Client diagnosed with hypertension suddenly develops a hypertensive emergency and begins to have a seizure. So the following interventions are most appropriate. We have assessed for the gag reflexes using a tongue blade and then documents the details of the seizure. We clear the furniture out of the client's way and restrain the client with soft elbow restraint. Hold the client to prevent injury and document the client details. Clear the furniture out of the client's way and remain with the clients. Let me see. Okay, so we all agree that we'll go for the 4 because that is the most appropriate intervention for someone with hypertension. Sorry, who is hypertension, who is seizuring, or who is having seizure. The 4th one is the most appropriate thing. So this is the question I want us to do together, or I want us to do. Then we move on from there to the last part of our class for today. Public health nurse is providing education to a client, to a group of clients regarding hypertension. Kindly mute up.
What is the different from what?
Because me call no say what friend.
The friend with.
All right. Which of the following does the nurse identify as the highest risk of developing hypertension? A 40-year-old female who is a secretary, a 50-year-old male who is a firefighter, a 20-year-old female who has a father with hypertension. Then we have a 50-year-old male with a BMI of 24. Yes. Give me your answers and your rationales. I'm interested in this question. So I could see others going for 3, others going for 1. Someone is going for 1 as well, 3. That is why I wanted to bring this question.
I'll go for 2.
Okay.
Okay, so I'll start my rationales from option 4.
Okay.
So the risk I'll use the risk factors here to do the eliminations.
All right.
With the 4, we have the age and then the male, which is a factor, but the BMI here is a normal BMI. So we only have 2 risk factors here.
2 risk factors. Okay. All right.
Okay, so option 3, we have 24 years.
Okay.
It's not a factor. Female is not really a factor, it's the male. And then a father who has hypertension. A father who has hypertension is a risk factor here. So I'll go for just 1 option here for the person.
One risk factor, okay.
Okay, so I'll come to option 2.
Okay.
So 56-year-old is a risk factor.
Okay, so 1 here.
The male is a risk factor 2.
2,
The firefighter is a strenuous work. So 3.
Okay. 3. So she gets 3. He gets 3, sorry.
Okay, so the option 1, secretary is a risk factor, so 1.
1.
Female is not a risk factor.
Okay.
Yeah, 40 can be a risk factor. It falls in between.
Okay. So
among them 3, I think 2 has the highest risk factor. So I'll go
this
for that.
also 2. So and then you arrive at this having more risk factors.
Yeah.
So okay. So Lako has given us her answer. Is there anyone thinking something else? Is there anyone with a different thing? Don't switch your answers because as our colleague has given us her answer and rationale, probably your own is the right thing. Probably what you are saying is the correct thing. So you can stick to whatever you think, but you need to make sure that you are giving us your rationale. Okay. All right. Do we all agree to what our sister has done, or we have a different view? If you have a different view, come up with your okay. So thank you, Lako. She's very right. Okay, and that is what I wanted us to learn. So the second one is the correct answer. And so when it comes to determining who is at risk, highest risk, you have to look at how many risk factors each patient presented to you, how many risk factors do they have? So you look at the risk factors. After getting the risk factors, then you can now arrive at your answer. Okay. And I think she did justice to that. And I like the way she went about her answers. And then, so that is it. I think we would continue from there So thank you all for your contribution during the answering section. We are coming to use the remaining hour to talk about pharmacology. We go through at least some of the medications, and when it comes to cardio, more of hypertension or antihypertensive medications and all that. That will be looking at the key things with them. Okay, and then we looked at them, we learn about them, and then we will drop it there as well. So that is it. If you have any question, if you have any inputs you want to make, you can bring it on board as well too. Before I start with my pharmacology or my medication, I'll be a bit faster here because I want to finish the remaining thing before. So then we go through some questions as well. So I'll need to do that within 45 minutes. Then I think I can do that. All right. All right. So let's look at the medication, starting with our anticoagulants. We all know the anticoagulants. We know them. You can't be a student of NCLEX without knowing about heparin, warfarin, without knowing about enoxaparin, without knowing about the antiplatelets as well too, or without knowing about your thrombolytics and all those things. So we'll start with the anticoagulants. And then what the anticoagulant, the first thing we'll talk about is the heparin. And I believe we all know heparin, that heparin, it's a blood thinner. In other words, someone will say it's a blood thinner. What it actually does is that it's helped to prevent clots from enlarging, and it also helps to prevent further clots from developing. And so, for instance, if a patient is having, let's say, any DVT or deep vein thrombosis, or a client is at risk of what we call clots developing, or is at risk of developing clots, we give the anticoagulants or heparin to prevent clots from occurring or developing. Or if the client is already having clots, the heparin will help prevent the clots from enlarging and then further clots develop. It will not actually dissolve it. Okay. And so what it does is that it prevents thrombine from being converting into fibrinogen to fibrin. The mechanism, the clotting cascade, or the cascade of events that leads to blood clotting. That is what so it helps to cut off that clotting cascade, or the events that leads to clotting. And so it prevents thromboembolism. The therapeutic dose does not dissolve clots, but prevents new clots from happening. Our interest when it comes to heparin is understanding the diagnostic investigations or the labs that are used in monitoring what we call heparin. And so we all know that in heparin, we use activated partial thromboplastin time, that is APTT, in managing what we call in monitoring the effectiveness of heparin. And so if you are giving heparin, you need to monitor the APTT level to know as to whether you are achieving your goal with the medication you are giving, or you are not achieving your goal. And so you need to either increase the dose of the medication, or if the goal has been overachieved, that means that maybe the client has been overdosed. You need to taper the medication down and all those things. So we'll learn about this. So we use the APTT, and I want everyone here to know that APTT is what you use to monitor heparin. And in there, we have the normal APTT level. And so for a normal person like myself, like yourself, who is not on heparin, who is not on any anticoagulant, if we go and check our our activated partial thromboplastin time, we should range between 30 to 40. That is for normal person, for someone who is not on heparin, okay, or someone who is not having any bleeding disorders. Your APTT level should be between 30 to 40 seconds. Now, if you go on heparin, or if heparin is given, what we should know is that this APTT level will go above the 30 to 40 seconds. So that means that your blood is becoming more thinner. And so you stand at high chances of what? Of bleeding. And so when you go on ATT, so when you go on heparin, we now expect the APTT level to go up. And so if you want to now know the APTT, the therapeutic level for someone on heparin, what you do is that you multiply the 30 to 40 seconds by 1.5 to 2.5 to get the therapeutic level. So let us all do this mathematics. So that means that if someone is on heparin, we are saying that the normal APTT level is 30 to 40. Okay, now we are saying that this is for normal person who is not on any anticoagulant. Immediately you go on an anticoagulant, we expect these levels to go up. That means that your blood is becoming more thin. And so to get the therapeutic level, because of the drug you are giving, you multiply these values by 1.5 to 2.5. Okay, sometimes some of the books, the ranges might be maybe 0.5 difference, but I think this is quite a standard one. So so what you do is that you multiply the 30 by this, you multiply the 40 by this. So at the end of the day, you are getting somewhere around 90 for the upper value, and then you are getting this somewhere around, I think 70 or 60 something. So ideally, if someone is on heparin and you check their APTT level, what you should know is that the patient should range between 70 to 90. If you have a patient on heparin, after checking the APTT, their APTT level is less than, I think, 60. It tells you that the medication it's either not, you need to increase the dose. If you are getting something less than 60 for someone on heparin, okay, and then the APTT, you check it and the person is getting less than 50, multiply 30 by 1.5 and let me see. And okay, let me do this calculation before. So 1.5 by 30, sorry, 1.5 by 30. So sorry, that is 45. Okay. So that means that it's not 60, that is 45 rather. So it means that if someone is on heparin, we want to see the APTT between 45 to 90. If you multiply the 2 by 2.5, I think 40 by 2.5, you are getting 90. And so between 45 to 90, that is the normal therapeutic range for APTT in terms of someone on heparin. And so if the level is less than 45, that means that you need to increase the dose of the medication. Equally, if you check the APTT for someone on heparin and then you get something above 90, sometimes they will say 100, okay? But anything above 90, it means that the medication is being overdosed or the medication is in excess. You need to reduce the dose of the medication. If not, the client will be at high risk of bleeding. So you need to do that. So the last portion or the last part of my slide says that if the APTT is too long, the agency procedure, the dose should be lowered. So if it is too long, it means that you check it and it's above 90 or 100, you need to lower it. If it is too short, that means that it is also less than 45. That also means that you either need to increase the dose of the medication. So that is on heparin and then APTT and all that I want you to understand today. In case you've been struggling to get the understanding, you can pick it from here. I'll go through it. If I'm done and then you have a question you want to ask, you can ask of it. I think sodium also has a bit of effect on what we call heparin. And so when you are giving it, you need to monitor the intake of sodium and all those things to limit their intake. I wouldn't waste much time here on it because the sodium aspect, I don't like asking a lot of questions on that. But my intervention for someone who is on heparin, you need to monitor the APTT level. You need to monitor the platelet counts. And you know that if someone is, the platelet count is also less than, I think it's between 150 to 400,000. So 150,000 to 400,000 is a normal range for platelets. So if you have platelets being less than 150, mostly it becomes very serious when it is less than 100. So when you have the platelet count being less than 100, you also should be aware because the client is also at risk of bleeding. Yes, Madam Tia. Yes, Tia.
Hello, sir. Yes. Hello, sir.
Yes,
and please, the calculation, the 40 times the 2.5, I got 100.
You got 100. So yeah,
yes.
I think you got 100 by
yes,
2.5.
Yes, please.
Oh, okay. So let's take 100. Okay.
So and you said if it's above 90, that means that
so that okay.
There's something
So,
going on. So I'm not confused. Yes, please.
Yes. So let's take the 100. So when you do, if you multiply and it's 100, that means that it's 100. I think I was taking 90. I thought that 45 by 2.5, 40 by 2.5 is giving you 100. That means that it's between 45 to 100. Okay. But I think I saw some questions in UWord where I think the APT was about 90 and then they were saying that you need to stop the medication and inform the healthcare provider. But based on this, I think in other situations too, 100 is okay. So between above 100, it's where you need to intervene. Okay. Let's take the 100. Okay. Madam Tia, thank you for drawing my attention to that. All right. So you need to monitor for signs of bleeding. Any form of gum bleeding, you need to monitor bruises, nose bleeding. It could all be as a result of the heparin you are giving. Probably the medication is being overdosed. So you need to monitor that as well. And then occult blood, that is blood in stool. But here, if someone is taking heparin and then presenting all these things, it tells you that client is bleeding. So you need to quickly inform the healthcare provider. You instruct the client regarding the use of measures to prevent bleeding. And so in measures preventing bleeding, especially if they are to shave, they must make sure that they are using electric shaving devices. And then injection, you have to make sure that you are limiting injection as much as possible because injection and then all those things could lead to bleeding. Then we all know the antidotes is what? Potassium sulfate. And so anytime you are giving your heparin, you must make sure that you have the antidote at hand so that in case a patient is bleeding, you give your antidotes. And in terms of giving it mostly it's given into the abdomen with the type of needle you use is also there, which I wouldn't worry you about it. For those that comes in a pre-filled syringes, you make sure that you don't aspirate, okay? Or after giving it, you don't also rub the area or anything like that. So those that comes in a pre-filled syringes, I think the enoxaparin, we'll do enoxaparin just, briefly. Enoxaparin comes in a pre-filled form. You must make sure that you are not aspirating anything. You just give it straight, okay? That air over there helps to push all the medication inside. So you don't need to, expel the air. That is what I want to mean say. Expelling the air for those that comes in the pre-filled syringes. You don't need to expel the air inside because the air will help push whatever in there. And we know that heparin is given in an IV form. We don't have an oral heparin there. So if you are reading your questions and then they are making mention of oral heparin, you need to know that we don't have PO heparin there. So in that instances, you need to report to the healthcare provider. It could be that it was a mistake with the writing or the order. And then we also have the IV form where you can give it with IV infusion and all those things. So, or infusion pumps are also there. And then it is also, you can use it for pregnant women. It's something I want to make mention of. So you know that heparin can be used in pregnancy. And those heparin or
Hello.
Rosabam, yes, Ruth.
So thank you for the presentation. Please, so I would like you to throw more light on. You said something about injecting air or something, which
Sorry,
was not clear.
I said I think it's even in the enoxaparin aspect. Some of them comes in a pre-filled syringes. So in that instance, you don't need to like take a needle, withdraw the heparin, and then give it. Okay. So those that comes in the pre-filled syringes, they have some form of air bubbles in there.
Okay.
In the syringe. So when you are giving, because we are
that one
used to,
IM or IV or something.
he said,
Please, that one is IM. I haven't seen some before.
a
That's why.
subcutaneous.
Okay.
A subcut.
Okay.
So you wouldn't want to expel the air, or we don't expel the air inside it. But what the air does is that the air helps to push the whole, the actual dose into the, if you expel the air, you are likely going to affect the dose that you give to the client. So we don't have to expel the air. Okay. So
okay,
that
so
is,
okay, so please. So if I can understand you well, this air issue only deals with the heparin injection that has
any injection that comes in a pre-filled form.
Okay.
If you have an injection that comes in a pre-filled form, okay, and there is air bubbles in there, don't expel the air out.
Okay.
Yes.
Thank you.
Yes. All right. So enoxaparin is like another form of what we call the heparin, but this time around the action is the same thing. What it does is that this one gives, like, in terms of the half-life of this one is a bit longer. So that means that when you give enoxaparin, it stays in the system for quite a long time before it affects its weight of. Okay. And this one mostly comes in a pre-filled form. So like I was saying, if it comes in a pre-filled syringe, you have some air bubbles in there. Don't expel the air bubble in the pre-filled syringe. And then after, or aspirate during injection. You don't have to aspirate like I explained. So that is on enoxaparin. You can also have rivaroxaban, which can be given orally, or which is given orally. It's monitored using the anti-SA assay, which is the therapeutic range for that one is 0.5 to 1.2. Not that one, they don't really ask a lot about it, but it's also the anticoagulant is also this. The antidote is also potassium sulfate, okay, because the component is also of heparin. So if someone is on enoxaparin or someone is on Rosabam and then they are bleeding and you need to give an antidote to it, you go with the potassium sulfate. Then quickly on warfarin. Warfarin works the same as someone, just its function is just similar to that of heparin. Just that we have clients that you can give heparin and those that you can't give warfarin to. So like I just said, if someone is pregnant and the person will need an anticoagulant, you can't give them what we call warfarin, because warfarin, it's contraindicated in people with pregnancy or people who are pregnant. And then if you are giving warfarin, you can give both warfarin and then heparin together. One thing is that when warfarin takes about 3 to 5 days for the effect to be seen. And so if someone is at high risk of having clots okay, or developing clot, mostly the healthcare provider will pair the two together. And what you do is that you give your heparin and then your warfarin at the same time, but you need to drop one at a point and continue with the other, because heparin will produce effect immediately. When you give the two, the heparin will start, or the effect of the heparin will be seen, and then in about 3 days time, the warfarin will also, the effect of the warfarin will also set in. So in that instance, you drop the heparin and then you continue administering the warfarin as well too. Then in certain conditions, heparin is used. So people with what we call atrial fibrillation, people with thrombosis, myocardial infarction, and then heart valve damages, they make use of what we call warfarin because of clot formation. We know that in atrial fibrillation, those of you who have gone through the EKGs, I believe you know what something about atrial fibrillation. Or in atrial fibrillation, there is a quivering of the heart that leads to clots. So there could be clots in atrial fibrillation, or people with atrial fibrillation are at high risks of developing clots or clot formation. And so in order to prevent the clot formation, they mostly go on warfarin, or warfarin is mostly given to people with atrial fibrillation. And in what is used to monitor the effect of warfarin is PT, or Potomac time. You can equally use the INR, or the International Normalized Ratio, to monitor the effect of warfarin. And so when you want to use what we call the Potomac time or the PT, the normal for someone who is not on warfarin is 11 to 12.5. So 11 to 12.5 seconds is the normal PT level. But if someone goes on warfarin, we now want to see the level going up. So that one, you multiply the normal levels by 1.5 to 2, then you get the therapeutic level for someone on warfarin. So you did the calculation just like what we did when we're talking about warfarin. So you multiply, so when we're talking about heparin, so you multiply the 11 by 1.5, you multiply the 12.5 by 2, and then you get your values. Then when it comes to the INR, the normal levels are also 1.8, 1.2. Now, for someone on warfarin, if you are monitoring the INR level, it should be about it should be between 3 to 4 points. I think it should be between 2 to 3. Yes, for someone on warfarin, if you are looking at the INR. So for that one, we don't multiply. For INR, we don't do any multiplication. We just look at the values. So for someone with on warfarin, if you are giving warfarin and you are monitoring, we are using the INR to determine the effectiveness of the warfarin. It's not the INR, or the therapeutic INR for someone on warfarin should be between 2 to 3. Okay. It also says that for people with something like atrial fibrillation, who are at high risk of what we call having clots, in that instance, we increase the dose of the warfarin, or the doses of the warfarin is mostly increased for people with what we call atrial fibrillation, because they are at very high risk of having what we call clots developing. In that instance, we increases mostly the doses of the warfarin is mostly increased. And so when the doses are increased in that instance, you wouldn't expect their INR level to be between the 2 to 3. They mostly have about 3 to 4.5 for people on high dose of warfarin. Their INR is 3 to 4.5. And so an example of a patient who will be on a high dose of warfarin is someone with atrial fibrillation.
Yes, the times are here.
Mokobi, for muted. Are you asking a question? Thank you. So the treatment goal of warfarin is to raise the INR to an appropriate level. So INR of 2 to 3 is appropriate for standard warfarin dose. And then 3 to 4.5 is for high dose warfarin therapy. So for those with atrial fibrillations and all those things, like I said, they are at risk, high risk of having clots. They mostly go on high dose of the warfarin. So if someone with atrial fibrillation is on warfarin and they are having INR between 3 to 4.5, you don't need to worry yourself a lot, or no need to inform the healthcare provider in that instance, because it is normal for them, or because they are on high dose of the warfarin. That is why if they are getting that value, you don't need to worry yourself a lot. Here too, you institute your precautions, your bleeding precautions. You need to institute all those measures. You monitor the PT, the INR, the gum bleeding, and all those things we talked about. And we need to know that certain foods, okay, like foods that contains much of most of the green leafy foods, okay, like broccoli and all those green leafy foods, they has what we call high content of vitamin K. And so we also know that vitamin K is the antidote for warfarin. So if someone is taking warfarin and then they are experiencing bleeding, they go on what we call the antidote for it. It's what? It's vitamin K. I think the other name for the vitamin K is the phenytoin. I always don't want to mention this, but whatever we all want to, however you mention it, the most important thing is I need to, when you see it, you should spot it that this is the antidote. It's the same as vitamin K. So wherever you see vitamin K, we should know that it's the antidote for what we call warfarin. And so if someone is taking warfarin, you need to limit the intake of high vitamin K diet, or foods that contain much of vitamin K. I think I have it. I will just present it very shortly so that we learn on it. And so I just group this so that we know which of the anticoagulants we can give them orally and which of them are through parenteral means. And so the oral ones, warfarin is oral, okay? We don't have IV form of warfarin there. We don't have subcut of warfarin. We have PO warfarin, or oral warfarin. And then when it comes to the IV, like I said, heparin is one thing I want to also let you know, that we don't have oral heparin, but rather we have IV heparin, we have subcut heparin, and then the other anticoagulants are there. But the major ones are the ones that I've touched on. These are the things that if someone is taking anticoagulants, the person will need to do everything possible to either avoid them or limit their intake. So example of them I'll touch on is the herbs that can affect the coagulation levels. And so if someone is taking either warfarin or heparin, the person has to do everything possible to limit their intake of Kigo and then that of ginseng. This kind of herbs affect what we call clotting, or can cause either affect the effects of warfarin and then heparin, or they can increase the effects of what we call heparin and warfarin. But with the green leafy and then the green leafy vegetables that contains much of vitamin K, it will be most with people taking warfarin, because we said that vitamin K affects the warfarin levels. If you go ahead to take much of the green leafy vegetables, it can equally affect what we call warfarin therapeutic effect in the system. Madam Amma, your hand is up.
Yes, please. In the test, when they are, I know, as for the oral medications, I know about the rivaroxaban and then the warfarin. Those are the only two that I've come across.
Yes,
so
those are the most common ones in the English.
That one, rivaroxaban, what we call it here is the Xarelto. So I'm going to present this in an exam for you to know, to be able to do, because I know the warfarin is called, that's the Coumadin, isn't it?
Yeah, same as Kimedi.
So Coumadin is the warfarin. But I don't know what else they are going to call rivaroxaban, because I've not seen it anywhere.
It doesn't have any other. If it was to be other name, I believe you might have seen it.
Because rivaroxaban, the one we have here, the rivaroxaban, the name is Xarelto.
You said the name is what?
Xarelto.
Okay, so I think myself too, I haven't come across it, but mostly they use the rivaroxaban. Okay, I think it's only the warfarin that they either use the warfarin or Coumadin. And even if they are to use Coumadin, you see warfarin first, then they will put Coumadin in the bracket. I don't know whether you've come across it more times.
Okay.
Yes.
Hello.
Yes.
I think they also use the oral apixaban.
Okay.
As known to be Eliquis.
Okay. So those in the US are talking. Nanaya, you were you were talking. I want to hear your part, Mr. Nanaya.
Hello. No.
Yes, let me hear of Ms. Nanaya, then we come to Madame Rosemary.
Like I was saying, the most used oral medication for anticoagulants is the oral ones are Coumadin and then apixaban, which is normally known as Eliquis. Those are the most Eliquis.
Okay.
They're very known ones used in the US. Probably I stand to be corrected though.
Okay. Thank you. Rosemary, you also wanted to come in.
Yes. I just wanted to relieve our sister from her concern, in that the generic name is the rivaroxaban, and over here the trade name for that particular drug is the Xarelto.
Okay.
So if you can really observe, you see that anytime sometimes you purchase a drug, you realize that definitely you see the generic name and sometimes the trade name in a bracket. And the same way, sometimes when you observe the NCLEX questions, they bring the generic and then put the trade name into bracket. Yes. So if you are not familiar, there's no need to be like familiar with the trade, but rather the generic, so that anytime you can definitely identify that this is the kind of drug they are talking about. Thank you.
Thank you. Thank you all for your inputs. I think we've learned something as well. All right. Thank you all. So at least we need to know the oral ones and then the ones we can give in the either IM subcuts or IV and all those things. So these are things we need to know when someone is taking anticoagulants. They either reduce the effects of the medication or they can potentiate the effects of the medication. So you will need to know this. But for this green leafy, the gigo, those have, the herbs, and then the food ones, we all need to know about them as well. Okay. Then NSAIDs, we also know that NSAIDs have effect on platelets, especially aspirin. And so we need to avoid all those things. They can have effect on what we call anticoagulants. So we just need to know that and avoid them as well. Then we talked about thrombolytics. Just quickly on thrombolytics. Now we've talked about the anticoagulants. We learned that the anticoagulants, what they do is that they prevent clots from forming, and then they also prevent clots that are already in there from enlarging. Okay. Now, the last time I was asking, so what is the difference between the anticoagulants and what is the difference between the thrombolytics? Now, the thrombolytics actually dissolves clots. So if a clot has been formed and then they want to dissolve the clots, they want to dissolve the clot that has been formed, it is the thrombolytics that they will give, or it is a thrombolytic that they will give to help dissolve the clot. And so examples of the thrombolytic is altiplase, retaplase, and then tenecteplase. Now, if you can't keep these things in your mind, or you can't keep these things, for you to know that this is a thrombolytic, look at the ending parts. Okay, so if you look at this, all the ending parts, or let's take it from here, they end with T-place, okay? They end with T-place. So any medication, probably maybe you will not go and meet these three in there, but I think these are the most common ones in the NCLEX that you see is a lot. If you are not meeting this and then go and meet something with T-place, okay, you just have to know that it is a thrombolytic and then it is being given to dissolve a clot. And it's mostly given for people with deep venous thrombosis, those with occluded shunts, okay, and then they will need to give something to open up, or for catheter occlusion for those with pulmonary embolism, and then ischemic stroke, very, very common with people with ischemic stroke. And we know that in ischemic stroke, it's either a clot that has blocked the supply of blood to the brain, leading to the stroke. And mostly when someone is having an ischemic stroke and you need to give a thrombolytic, there is a time duration in which thrombolytic is given to people with what we call ischemic stroke. And so if you look at, I think, my fourth point or so, it says that thrombolytics are used early in the course of myocardial infarction, and those with, I think, ischemic stroke too. You have a time duration by which you can use what we call thrombolytics. And so the time duration is between 4 to 6 hours. I think in other Cubans, they will even stress that you need to give thrombolytics within 4.5 hours from the onset of the signs of the ischemic stroke. So the timing is not from when the client reported to the hospital. You ask the client when they started experiencing the symptoms. And so you start counting the 4 hours from when the client noticed the symptom, or you ask the family when they notice the symptom. Then you start counting your hours from there. So between 4 to 6 hours, that is when you can give what we call a thrombolytic for people with myocardial ischemia or myocardial infarction, and those with ischemic stroke. Okay, that is a time duration for that. So like I said, you use it to dissolve the clot. Here, it is also very important that we all need to know that we don't give it for people who have active internal bleeding. So if a patient presents with active internal bleeding and the healthcare provider has given a thrombolytic, we know that thrombolytics dissolves clot, and it doesn't have a specific clot that any clot that is within the system, this thing will dissolve it. And so any patient who is at high risk of bleeding, we don't give them a thrombolytic. So active bleeding, in active internal bleeding, thrombolytic is contraindicated. People with hemorrhagic stroke, because in hemorrhagic stroke, if you look at the pathophysiology and all those things, it's about what we call an aneurysm that might have ruptured or that has ruptured, pouring more blood into the brain, okay, depriving the brain of, oxygenated blood. And so what you do is that you don't give thrombolytics to people with signs of ischemic stroke, or hemorrhagic stroke rather. You don't give it to people with hemorrhagic stroke, those with increased intracranial pressure, or those with intracranial problems like trauma, because in intracranial pressure, one of the things that mostly causes it when there is head injury, and then there's bleeding in there, you don't give it. And then anyone with intracranial or intraspinal surgery within the previous 2 months, they are also not a candidate for thrombolytics. And then anyone who has also had an abdominal surgery or thoracic or pelvic surgery within the last 10 days, they are also not candidates for thrombolytics, because it will dissolve any clot in there. It could equally affect the integrity of the surgical site. And so that is why you don't give this. And anyone with hepatic or renal issues, uncontrolled hypertension, they are all not a candidate for thrombolytic medication. So we need to know, especially most of the questions they will ask, like the surgery things. The client has had surgery within, let's say, a few days, and then they have been put on a thrombolytic. What are you going to do? So you need to know that in that instance, you need to make a follow-up with the healthcare provider because they can't go on with the thrombolytic. Here too, you monitor the clotting factors, you monitor your APTT, you monitor the PT, and all the things that will tell you that a client is bleeding. Vital signs is very important. You have to check for bleeding and check all, excretions for occult blood. Then you check the neuro status, because if someone is bleeding, there is any form of intracranial pressure going up, and this person is on what we call a thrombolytic, will be that it is a thrombolytic that is causing those kind of neuro changes. You need to monitor all those things. Then injections, you need to be very careful with injections. And if you give any injection or apply direct pressure over a punctured site for about 20 to 30 minutes, especially after venopunches, okay? Or if there is any form of injury, in order to help with occlusion of the vessel, you apply direct pressure over the affected area to help stop bleeding. And then you handle the clients gently, and then prevent any form of unnecessary movement that could lead to bleeding. You use electric razors for shaving, and then soft brush for brushing the teeth is what you use. You don't use anything that can lead to what we call bleeding. So you have to limit that. So that is on the thrombolytics. If you have any input, you have any question you want to ask, you can bring it on board, or you can add it as well too. Before we go into the dosing, we'll talk briefly on the dosing and then. Madam Amadate, Dinadate, sorry, informated. Okay, let's talk quickly on, dejosing or decalcing or whatever, however you mention it. That is up to you. Now, I'm not going to talk about the the doses and whatever, but all we need to know, what comprises or what tells you that someone on dejosing is having dejosing toxicity. What are the managements? What are the labs you need to monitor when someone is on dejosing? Okay, that is what I want to do. And so when it comes to dejosing, we know that it is a cardiac glycoside. That is what they say it is. And then mostly helps to reduce what we call heart rates, and then it's also useful in people with heart failures and all that. So in people with some form of dysrhythmia, it's okay, they make use of dejosing as well too. Now, my interest for today's class is that we need to know the adverse effects of what we call dejosing, and then the management when someone is taking dejosing. And so when it comes to the side effect for dejosing, we need to understand that if someone is on dejosing and the person is complaining of nausea, vomiting, and diarrhea, any form of GI abnormality with dejosing tells you that the person is developing dejosing toxicity. So you need to quickly inform the healthcare provider, and the dose will need to be stopped as well, or the medication will need to be stopped based on the facility protocol. But all that I want you to understand is that nausea, vomiting, diarrhea are the early signs of dejosing toxicity. And so you need to monitor these things. And if a client complains of this, you need to understand that as well. Then you also have bradycardia, because we said that this medication helps to control heart rate. And so if someone is having a high heart rate, in instances, dejosing is given. And so you need to monitor the heart rate. And so one thing to also do before you give dejosing is that you have to monitor the apical pulse. Okay, you need to monitor the apical pulse. And if the apical pulse is less than 60, the medication will need to be held, or the dose will need to be held. Then when some of the, other side effects or adverse effect that tells you that toxicity is developing is when there is any form of visual disturbances or any form of visual changes. If someone is on dejosing and they are complaining of visual changes, you need to know that they are developing toxic levels of the medication, and you need to, either stop the medication and inform the healthcare provider on that. Headache is also there, fatigue, drowsiness, and then weakness. They are all there. So in the last part of this, I've said that note early signs of digoxin toxicity present with gastrointestinal manifestation like the anorexia, nausea, vomiting, and diarrhea. And then heart rate, visual disturbances will appear later on. So in my management for someone on digoxin, I said that you have to monitor for the early signs of digoxin toxicity or all the signs of digoxin toxicity. You need to monitor for it. Then you monitor the serum levels of digoxin, electrolytes, and the renal function. You need to monitor for it. So when it comes to the therapeutic level for digoxin, if someone is on digoxin, we want to see the serum level to be between 0.5 to 2.0. Okay, don't worry yourself a lot about the unit attached to it. Okay, but know the actual value. So 0.5 to 2.0 is your normal levels for digoxin, for serum for someone on digoxin. So anything above 2.0 tells you that there is digoxin toxicity. So you need to, as I said, you need to inform the healthcare provider on that, hold the dose, and then other things would also have to be monitored. Then what are some of the things that can put a client into or having toxic levels of digoxin if they are taking this medication? Now, some electrolytes need to be monitored. If someone is taking digoxin, you need to monitor some electrolytes like calcium, potassium, and magnesium. Okay, this electrolytes, okay, if there is any form of disturbances in terms of their levels, especially with potassium, it leads to what we call digoxin toxicity. So you need to make sure that these electrolytes are within their normal ranges. And so if you are giving digoxin to someone and the person's potassium level is less than 3.5, you either need to hold the medication and inform the healthcare provider. Because if you go ahead to give this medication in a hypokalemic state, you give digoxin to someone with hypokalemia, you can run the person into digoxin toxicity. So you need to hold the dose and inform the healthcare provider about this. So you note and you have to also know that people who are older or older adults are also at high risks of developing digoxin toxicity. So hypercalcemia, hypokalemia, and then hypomagnesemia, and as well as hypothyroidism all renders someone at risk of going into digoxin toxicity. So you monitor the client taking potassium sparing diuretics or corticosteroids for hypokalemia. And then if it happens, you need to know that the client can go into digoxin toxicity. For the potassium, let us all know it. I remember those days, people used to come and tell you that we met digoxin, and then they were asking which electrolyte affect digoxin and then the digoxin levels. So we need to know this. Then you instruct the clients to avoid over-the-counter medications as well. Avoid the client to eat foods that are high in potassium. And we know the foods that are high in potassium like banana, and then most of the fruit juices or the fruits with vegetables, potato, they are all made of potassium. So clients has to advise the client to eat foods that are high in potassium. Very well. So we are saying that hypocalcemia leads to digoxin toxicity. So you rather increases the dose of the potassium containing diet. Sorry for that. Then you need to monitor the apical pulse. Okay. You need to monitor apical pulse for people taking digoxin. And if the apical pulse is less than 60, you need to withhold the medication and inform the healthcare provider about it. So you have to make sure that the pulse is between 60 to 100, which we know that is the normal levels. And then you monitor for the toxic levels, signs and symptoms. The antidote is digoxin immune fab. Okay. I haven't really seen a question on that, but I decided to just add it to my slide in case you meet it anywhere. You know that this is the antidote for digoxin. So that is just briefly about digoxin. I want all of us to know, and then we put it aside. Then, if you have anything on digoxin, you can bring it on board as well, okay? Or you can raise it up, you can bring it to that we discuss. Then we talk about the ARBs, we talk about ACE inhibitors. And when we talk about the ACE, the ARBs, I wouldn't want to bring the list here because we know the ARBs, many medication that ends in Satan, okay? Cardizalpan, whatever Satan, they are all ARBs. Any medication that ends in trail, they are also the ACE inhibitors. And these medications, first thing I want to make mention is that it is contraindicated in people who are pregnant. It's not used in pregnancy, okay? It is a contraindicated medication in pregnancy. Then, when we are giving ACE inhibitors, we need to monitor the kidney function. I think I'll go to the management, but let's look at some key side effects I want to make mention of here, or I want to highlight. Now, the GI abnormalities, we know that when it comes to most medication, the GI symptoms are there. But when it comes to the ACE inhibitors, persistent cough is expected. Or someone, not persistent in general, but cough, dry cough is expected side effect for someone taking an ACE inhibitor. And so in your questions, you see that maybe someone taking ACE inhibitor is complaining of cough in the initial stages after being on the medication. When someone takes ACE inhibitor and then in the initial stages they are complaining of cough, let's understand that the cough is expected. But if it becomes persistent, that is when they need to make a follow-up with the healthcare provider, and then probably the medication will be switched or they will change the medication for them. But if it just cough in the first few days after they have been on the medication, no worry, just advise the client that it is expected. But if it becomes persistent, they will need to come to the hospital. Then I will also touch on angioedema. So angioedema is also peculiar to people taking what we call the ACE inhibitors. And so here, they will tell you that a client taking ACE inhibitor presents with some symptoms that looks like they are having what we call allergic reaction, okay? And they will present with angioedema. Angioedema is where you have the tongue, you have the lips all getting swallowed, okay? It becomes, there's some form of swelling, sorry. There's some form of swelling of the tongue, there's some form of swelling of the lips. And when it happens, it is the most serious side effect of ACE inhibitors. It can lead to airway blockage. And so for someone who presents with angioedema and they call you, what you need to tell them is that they need to stop the medication as soon as possible, because the angioedema could lead to airway blockage. Then you could also have diminished taste, which is also with ACE inhibitors. There could also be some form of insomnia. There could be tachycardia, hyperkalemia. It's also with people with ACE inhibitors. So when you are giving your ACE inhibitors, you need to monitor the potassium level. And so if someone is already having high potassium level and you need to give your ACE inhibitor, you need to inform the healthcare provider about that, because the medication already could lead to hyperkalemia. So potassium level needs to monitor. You monitor the kidney functions and all those things. That is your BUN and creatinine level, all needs to be monitored. Now, let me come to the intervention. I think vital signs is very important because this is hypertensive. You need to monitor for hypertension if someone is on this. I've talked about the potassium level, the kidney function. You need to monitor all these things. And then over-the-counter medications, clients need to avoid them as well. I believe we all know. Then there could be some form of bleeding related with what we call captopril. So for people who are taking captopril, they stand at chances of bleeding, or they could present with signs of bleeding, like bruising, petechia. So if it happens, you need to inform the healthcare provider on that. Then you instruct them to report any side effects that could develop as well too. So that is quickly on the ACE inhibitors I would want to touch on. I wouldn't want to wait. I think I have a lot to do. I want to finish all today. Then we have the loop diuretics. So when it comes to the loop diuretics, example of them is furosemide, okay? And I think butenamide is also another example of the loop diuretics. We know that this one will act much more on the kidneys, promotes what we call excretion of fluid, and then it will help reduce the blood pressure. Now, when it comes to the loop diuretics, one of the main things I want us to take note of is the potassium level, because they are potassium wasting, okay? They are potassium wasting. And so if they are potassium wasting, what it means is that they get potassium out of the system. And so if you are giving your loop diuretic, potassium is something that you need to pay much attention to it, okay? So you need to monitor potassium level. It could lead to hypokalemia, it could lead to hyponatremia. It could also lead to hypocalcemia as well too, then hypomagnesemia. But I think the most important thing that they mostly ask of is the potassium level. Then it could also lead to some form of platelet counts reducing, so thrombocytopenia, hyperuricemia. So you need to monitor uric acid level as well too. Then this could lead to hypotension, especially orthostatic hypotension. So that means that any change in the client's position could lead to a drop in their blood pressure. So you need to monitor that. Then ototoxicity, yes. So ototoxicity is something that we all need to know when we are taking, or when a client is taking this loop diuretics or furosemide. And because of that, if someone is taking loop diuretics, it says that in order to prevent the ototoxicity and then the deafness, you need to give the medication slowly over a period of, I think, 5 minutes, 2 to 5 minutes, to prevent the ototoxicity. But in our setting here, you know that someone is taking furosemide, you just go straight ahead, push it by, and then you are good to go. But we need to understand that the loop diuretics could lead to ototoxicity, and then we have to be very careful on that. You monitor the kidney level, the kidney function, then you monitor uric acid levels, because we said that it could lead to hyperuricemia. So you need to monitor uric acid level. Then to prevent the hearing loss, you must make sure that you are giving it over 1 to 2 minutes to prevent that side effect. You monitor the vital signs. Electrolytes, very, very important. Potassium level, you need to monitor that. You check the peripheral extremities for edema, because in essence, we are giving this to help remove more fluid from the system. So you need to. Then you have to monitor for signs of digoxin toxicity. Remember, we are saying that this medication can lead to hypocalcemia, and we know, sorry, hypokalemia. We said that this can lead to hypokalemia. And so in hypokalemic states, if someone is taking digoxin, it can lead to digoxin toxicity. Then, lithium, you need to monitor lithium levels as well too. And monitor for any lithium toxicity that can equally happen. Blood pressure, you need to monitor. High potassium diet, very, very important to replace the potassium that the client is losing. Then the potassium sparing diuretics, example of it is spironolactone. And we know that if you are giving the potassium wasting, you need to give something to counteract the effects of the potassium wasting. So in that instance, they will give the potassium sparing, which example that you see most common in the NCLEX is spironolactone. And so spironolactone will cause more potassium to remain within the system. And so one thing we need to know is that if more potassium is retaining in the system, then hyperkalemia is something that can result. And so in potassium sparing diuretic, one thing that we monitor mostly is the potassium level. So you need to look at the labs, and you look at which of the lab is potassium level up, is potassium level down, then all that. You need to also look at nausea, vomiting, the GI abnormalities, dry mouth, photosensitivity. And so for photosensitivity, managing photosensitivity, I think the clients will be asked to use sunscreen. If they are going out, they have to wear what we call clothing that will cover their skin and all that. And then so the primary concern in potassium sparing diuretic is the potassium level. You need to be very careful on that. Then you monitor vitals, very, very important. You need to monitor urine output. And we know that when there is any form of potassium disturbances, in the EKG, there's going to be top peak T wave. And so when there is any changes with potassium, especially in a hyperkalemic state, we know that in EKG, you're going to have top peak T wave. Okay, so when you are reading and you come across top peak T wave, or they are asking you someone with hyperkalemia or someone in a potassium sparing diuretic with a certain potassium level, what do you expect? And so you know that you're going to get a top peak T wave. It's something I also want us to also take note of. Then potassium level should remain within 3.5 to 5.0. Anything above 5.0 is a cause for concern. You have to limit the intake of high potassium diet. Exposure to direct sunlight should be avoided. Then you have to monitor for the signs of hyperkalemia. And then salt substitute. Any person taking the potassium sparing diuretics, they need to avoid salt substitute because salt substitute also contains high potassium. And so they will need to avoid what we call salt substitute. Then you instruct the clients about medication, taking the medication with or to decrease GI disturbances. My last, should I finish? Give me 10 minutes to finish, okay? Give me 10 minutes, okay? I know our time is up, okay? Give me 10 minutes to finish. Then the beta blockers, we also have the beta blockers. And so with the beta blockers, I know that I'll present the differences, okay? But when it comes to the beta blockers, what I want us to take very note of is that the beta blockers will affect the heart rate, will affect the BP, but the ACE inhibitors will not affect the heart rate that, okay? It's not really affect the heart rate. And so if you are giving beta blocker, you need to monitor the heart rate, you need to monitor the BP because it can drop all these things. And then it's useful for people with angina, hypertension, and then glaucoma, dysrhythmias, they all make use of it. But one thing I want us to notice that beta blocker in general is not really good for people with what we call respiratory conditions or people who tend to have airway issues like asthma, even though we have the cardiac specific, and then we have those that are not cardiac specific. We'll go through them. I'll present those medications very soon, and then you get to know which ones are cardiac specific and which one is not cardiac specific. Beta blockers should be used in caution with people with diabetics and those things. They are not really of high interest to me. Then we have the selective beta blockers and the non-selective. Selective beta blocker means that they only affect the heart. And so in that instance, if someone is having any asthma or any bronchospasm disorders, you can use the cardioselective in them. But if someone is having a broncho spasm issue like asthma, and then it gives the person a non-selective beta blocker, you need to make a follow-up on that because it will affect the bronchioles, or it cause bronchospasm, leading to occlusion of the airway, affecting the clients more. And so with the cardioselective, you can use it in people with asthma, okay, or people with airway occlusion disorders. So the cardioselective on the screen, you could see atenolol is there. We have metoprolol. I think they are the most common ones. You see it commonly in the NCLEX. You could have esmolol, you can have betasolol, we can have acetabutalol. They are cardioselective. And then the non-selective ones too, they are carvedilol, labetalol, propranolol. They are all examples of non-selective. And so the non-selective will affect both the respiratory system and affect both the heart. And so in that instance, if someone is having asthma or any issue with their airway in terms of airway blockage resulting from bronchospasms, you don't give them the non-selective beta blockers, but you go with the cardiac selective or the selective or the cardiac specific ones. The side effects, because they affect the heart rate, we could have bradycardia, bronchospasm, hypotension, and then it could also lead to agranulocytosis. It could affect the, it could cause hyperglycemia and all those things, nightmare, depression, and all these things are there. Vital signs are very important. You need to monitor. If the pulse rate is less than 60 and you are giving a beta blocker, you need to, withhold the medication as well. It could equally, monitor for signs of heart failure and then worsening heart failure. Then you assess any form of respiratory distress, wheezing, dyspnea, you have to assess for it. And so when it comes to beta blocker and asthma, it's very, very important. You need to know which ones are the cardiac selective and which ones are not cardiac selective, so that you can give. Then advise the clients that taking insulin, advise the client taking insulin that the beta blocker can mimic signs of hypoglycemia. So they should be very careful on that. Then they need to monitor their blood levels, the glucose levels as well. BP needs to be monitored. Hypotension, over-the-counter medications, all need to be avoided. Calcium channel blockers will be my last class of medication. I will talk about it, then I will drop it here. So let's do the calcium channel blockers. And then the calcium channel blockers, we have the nifedipines.
There's a message for you. Someone said you are rushing. I think you should
is the person want me to slow down a bit?
Yes.
Oh, okay. Okay. I wanted to finish this. That's why. All right. Sorry for that. Okay. So we have the calcium channel blockers. That will be my last part. But if in case I've said something and you want clarification, I will just drop it here. You can ask so that we'll go back to it again. You have the calcium channel blockers. And in general, you know that calcium channel blockers, someone will say that they are not quite useful in people with heart failure, okay? But because it could lead to what we call peripheral edema, it could equally lead to some form of fluid retaining within the system. So generally, the beta blockers are not quite good to be used in people with heart failure. So when you are using, you need to be very careful with that. Same thing applies to someone with bradycardia. You wouldn't use a calcium channel blocker for someone with bradycardia because it will further worsen their case. Same as someone with atrial ventricular block or a heart block. And so in heart blocks, already in heart block, they will have a bradycardia or their heart rate will already be down. So you wouldn't go ahead to use a calcium channel blocker. And so apart from these two medications, deltiazem, and then what is the other one? Deltiazem and then
Verapamil.
Verapamil, right? Is it verapamil? Yeah. Deltiazem and verapamil that do not follow the normal naming of calcium channel blockers. All calcium channel blockers will end in the pin, okay? And so if you have the nifedipine, whatever the pin, they are all calcium channel blockers. And then apart from verapamil and then deltiazem, they are the ones that are calcium channel blockers, but they don't follow that traditional naming. So when you come across deltiazem, verapamil anywhere, you should know that they are example of calcium channel blockers. What I want you to take very note of is, I think the hypotension it could cause, bradycardia it could cause. So when you are giving this, you need to monitor all these things. You need to use it with care in people with heart failure. It could also lead to constipation, and it could lead to some form of liver and then kidney disturbances. So you need to monitor all these things. And then fatigue, The management is that monitor vital signs. You monitor for signs of heart failure. Then you monitor for the liver, the kidney, because we say it could affect the kidney and the liver as well. Then you instruct clients not to discontinue the medication abruptly because it could lead to a rebound tachycardia or reflex tachycardia. Okay, so because of the fact that it could lead to a rebound tachycardia and then hypertension as well, we wouldn't want the client to discontinue the medication abruptly. If the medication needs to be stopped, it has to be done by tapering it down gradually. Then you instruct the client on how to take their pulse before they take the medication. And if they go on the medication, how to take their pulse. You instruct clients signs of hypotension like dizziness, fainting, then they have to inform the healthcare provider. And then most of this medication comes in a sustained relief form, or it comes in a sustained relief form. So you don't have to chew it, you don't have to crush it. Client has to swallow this medication. If it is stated that someone is taking a sustained released nifedipine, and the client tells you that I'm going to chew the medication or crush the medication, you need to know that this is contraindicated. Rather, you need to swallow this with water. So that is that on my presentation for today. And then on cardio, this is not all the cardio medications, okay? There are quite a lot of them that I've not touched on. And so I'll leave that to you. If you are doing your personal studies, you come across them, you add up to them, and then you take it out from there. So today we'll end the cardio here. And the next week when we meet, we'll look at what we do as well too. Thank you for your time. Thank you for staying with me. Can we do 1 or 2 questions on that? Yes, Priscilla, you have your hand is up.
Yes, please, I have a quick question on, you made mention of warfarin and heparin being used concurrently. I just wanted you to touch on it slightly. I don't know, I think I missed it.
So what I said was that, yes, warfarin and heparin can be given concurrently, or you can give them at the same time. But both of them, the effects will not be seen at the same time and then the client will not be on the 2 medication for a long time or will not be on it continuously. Clients will be on both, but it gets to a point, they will drop one and the clients will continue with the other one, because if they continue to be on it for a very long time, both of them will produce the same effect and the client will be at high risk of bleeding. So if someone needs to be on the 2 medication, this is how they do it, or this is how the healthcare provider will do it. The healthcare provider will prescribe the 2 at the same time. Client starts with heparin, the client starts with warfarin at the same time. But warfarin takes about 3 to 5 days for its effect to be seen. Okay, for its effect to be seen. So when the client takes the heparin and the warfarin, the heparin will start working. Immediately the client takes it, heparin will start. But when it gets to 3 days, from 3 to 5 days going, or after 3 days, then the healthcare provider will stop the heparin and the client will continue with the warfarin. By then, the warfarin might have started manifesting, or the effect of warfarin might have started. And so the client will continue with the warfarin after 3 days, and then the heparin will be stopped. So that is how to give the 2 concurrently. If you meet a question on that, that is how they give the 2 medication together. That person, are you okay?
Yes, thank you. So sorry. So you're saying they are given together at the same time, but yes, the warfarin starts working in like 3 to 5 days, but the heparin starts working immediately.
Yes.
Thank you.
Madam Ellen, your hand is up.
Yes, sir. Please, thank you for the presentation. So my question is with the giving of heparin.
Okay.
I know it's subcut, but I think some of the pre-filled syringes says you can pinch the skin fold forward and give it at an 90-degree angle. I don't know if that's true.
Yes, that's true.
Okay.
Yes.
My NCLEX wouldn't permit that. So
so I think sometimes it depends on which patients you are giving. So sometimes some of they tend to ask about some of those who are obese and then those who don't have a lot of fat as well too. Okay. They tend to bring that as well too. So, but the 90 degrees, yes, even if you are giving the 90 degrees, you know that the needle is such a way that I think it will still be subcuts because the needle is very small. I stand to be corrected though, because it might not be able to penetrate
yeah,
into, it's very small. So even if you are
the
giving
deep
it the
muscle.
90, it's those who have fats and those who do not have a lot of fats. So those who have the fats, I think those are the people that you have to pinch and then give it 90 degrees. But for those who don't have a lot of body fats, you give it the subcut, I think 45 or so. Yeah.
Okay, thank you.
Yes. Anyone with any question, any clarification, any inputs? We can drop it here. We couldn't go through questions on cardio medications and drugs. That is okay. All right. So thank you all for staying with us. My last announcement was that when I said that we will have a program coming up for those of us in Ghana. Inform your friends that we'll be having a program in Accra and Kumasi, and then the program is on 20th November in Accra, and then in Kumasi is 27th. So it's a week interval. So we'll start our advertisement and you see the venue and everything. So we invite you all. You come with your colleagues, you come with your friends, can invite them to also come and then hear what we do and some of the things that we can assist them if they want to do their NCLEX. And so that is that for today. Thank you for your time. Thank you for staying.
Yeah,
with me. Yes.
Yeah, so with regard to the upcoming program, we will first share the registration link to our masterclass page so that we will have first-hand registration before we come out publicly. So probably tomorrow evening, we might share the link so that Monday it goes out publicly. Thank you very much. We want your patronage and then sharing of the link as well once it's out. Thank you very much.
Okay.
Okay,
So I think,
sir,
okay.
please, can you let us solve the question that I'm seeing right now, like the one that you've projected? Then you go.
Can you do?
I said, can you let us solve this question, the one that you've projected right now? Then after that, then we call it a day.
Oh, okay. Okay. So someone is requesting for us to do this question and you drop it here. So we have the nurse caring for a male client in a cardio unit. The nurse has reviewed the client's medication order to manage their symptoms of heart failure, which findings made by the nurse is their highest concern. So there's exhibit. So this is my exhibit. Type 2, in the medical history, in the exhibit, there's a medical history of type 2 DM and then erectile dysfunction. The client takes metformin, client takes sildenafil, client takes acetaminophen, no known allergies. The order at the moment is nitroglycerin capsule, 5 milligram POT TID for the management of the heart failure. Vital signs are that pulse is 92, respiration is 19, blood pressure is 145/87. We have the question is that which of these will be of high concern? We have the options are the client's treatment for DM, the client's recent blood pressure results, the client taking acetaminophen PRN, the client treating erectile dysfunction. I believe this one is very simple for us. I think I made mention of it. If I didn't make this on nitroglycerin, within nitroglycerin, when we're talking about angina is okay. And so, and that of heart failure and then that of MI, we did talk about nitroglycerin then. And I think they are answering in the comment section 4. And we all know that if someone is taking nitroglycerin, the person doesn't need to take sildenafil. Okay. Sildenafil taken together with nitroglycerin leads to hypotension. They are both vasodilators. And so you can't give two vasodilators at the same time. And so whenever you are reading your medication pharmacology and you come across the sildenafil, maybe might not be sildenafil. Sildenafil is the most common one you see. But I think they mostly ends with the nafil. Okay. So when you see them, you know that they are mostly used for erectile dysfunction, and you can't use them together with nitroglycerin. So you need to make a follow-up on that. That is just one question I wanted it to. Then the next, caring for clients being discharged home with loop diuretics, what adverse effects should the nurse reinforce during teaching? Low blood pressure, angioedema, low potassium levels, dry cough, fever, and all those things. I think yes, let's see. Okay, it's not SATA. Those who are choosing SATA for this question. Is this SATA? Okay, SATA. All right. Sorry, it's SATA. All right. So those who are choosing SATA, okay, yeah, it's SATA. So 1-3. People are going for 1-3. One is low blood pressure. 3 is low potassium. Okay. All right. Let's end here. We call it time for today. So I think we can end here for today. Thank you all. Okay, let's meet again on next week, Saturday, a week today, and we take it out from here. Thank you for your time. Okay, it's not easy to stay for 3 continuous hours.